The length of stay difference is the entire. It's well worth the price of the disposable device.
And the C-suite loves that.
Of course. I mean, the C-suite loves it, but the surgeons should love it too because it's better for patients, right? Less time in the hospital opens more beds for more patients to get procedures. It's better for patients. They're not getting 2 procedures and 2 anesthetics over several days. The risk of pancreatitis with a lap common bile duct exploration is extremely minimal when compared to an ERCP. It's good for patients. It's good for administration. I mean, this is a win all around, to be honest.
Hi, everybody, and welcome back to EndoCast. I'm your host, Leslie Bishop, and this is episode 28 with our physician guest, Dr. Eric Pauli from Penn State Hershey Medical Center. EndoCast is a GI-focused podcast for clinicians, by clinicians, presented to you by Boston Scientific. Together, we'll take a closer look at the data, techniques, and insights of endoscopy that matter most to listeners like you. Dr. Pauli, welcome to EndoCast.
Thanks for having me.
Super happy to have you. I'd love to get to know you a little bit. Tell me a little bit about your practice at Penn State.
So I'm a surgeon by training, and I'm a surgical endoscopist. About half of my practice is flexible endoscopy procedures. The other half is honestly complex hernia stuff. I call myself a peri-gastrointestinal surgeon. I work around the bowel and inside the bowel, but not on the bowel because that's ick. You know what I mean? If I'm doing your surgical anastomosis, it's a bad day for everybody. But other than that, I'm fine.
And I know you recently incorporated SpyDiscover, and I wanted to hear why you did that.
Yeah, so we had been doing laparoscopic transcystic common bile duct exploration at our facility for about 1.5 years or so prior to the launch of SpyGlass Discover. It was good for patients, and we felt that the struggle of using reusable equipment was worth it. But once something easier became available, we felt that it just made a lot more sense. Having equipment that's sterile, in package, readily available, never lost, you can damage it, but if you damage it, it's not a big deal because it's disposable. You're not spending a lot of money reprocessing and damaging what are intended to be used, multi-use scopes. Our urologists were not happy when we started using their equipment regularly. And so having SpyGlass Discover just made the practice take off. It also made it easier for our other colleagues who were less interested in struggling to adopt the practice. The surgical endoscopists in the group felt the struggle was worth it, but the rest of the group said, when this is a little bit easier, come back and we'll learn how to do it. And I think Discover just makes it easier for a non-surgical endoscopist to do.
And they've all come on board?
Yeah, we have 7 folks in our group, and we all now do lap CBDE as a group. Yep.
Oh, I love that.
Yeah.
Okay, so I want to hear about how you're using it both in bile duct exploration, but also in the PEBL procedures. Let's start on the bile duct exploration part. So when you're doing a lap chole, when and why do you perform an IOC?
Yeah, so I'm a routine bile duct imager. If the patient's low risk for a stone in their bile duct, never passed a stone clinically, never had abnormal labs, I just do an ultrasound. If I find a stone, then I switch over to an IOC. But for anybody who had lab abnormalities, who has a bilirubin that was up, who may have passed a stone clinically by their symptoms, we shoot a formal cholangiogram and identify stones if they're there.
And then if it's positive, what do you do then?
Yeah, if it's positive, the algorithm is, how positive is it? Okay, there are obviously people who do better with a common bile duct exploration and folks who do better with a postoperative ERCP. And so having some knowledge of who should I try this on is important. And there's a number of factors that go into that. Is it one small stone in a normal sized bile duct? That's an easy LCBDE. Is it 5 huge stones in somebody who has a small cystic duct? That's a different story. And so I think for clinicians who are taking this up, the ability to shoot a cholangiogram and identify people who are good candidates or bad candidates is the first step to making the procedure successful. If you're trying it on terrible candidates, you're going to be frustrated. You're not going to want to do it the next time. So you have to be aware that some patients are not good candidates for a laparoscopic transcystic bile duct exploration, and you got to have a backup plan, which at our facility is easy. I do ERCP as well. And so if my surgeons call me and say, we shot a cholangiogram, we were going to do lap CBDE. We can't. Are you available? I usually just pop down and do an on-table ERCP. That's not available at every facility. There are not surgeons who do ERCPs. You may have to call a GI colleague who may not be available at that moment. And so having a handful of bailout maneuvers, like can this person get an ERCP tomorrow, is probably the next bet for that person who's not a good candidate.
And so what are the benefits of going ahead and doing the bile duct exploration during the surgery?
Well, at a minimum, you are eliminating the need for advanced imaging. If you've got a patient who's got a question of, is there a stone here or not, you could absolutely go ahead and get an MRI. It takes time. It's a lot of money. The patient's in the hospital another day. If it's a question of is there a stone, those stones may be beyond the detection of an MRI. So even after the MRI, you're going to get a result that says something like, there may be a stone here. And you're going to shoot the cholangiogram anyway, right? And so for us, it just shortens that process. This patient's going to the OR for a cholecystectomy. We will shoot the cholangiogram, and if there's a stone, identify it. The majority of patients you can probably clear at that time, and if you can't, you get a post-op ERCP at most facilities. That would be the usual way that a facility adopting SpyGlass Discover would kind of change their algorithm.
And are you hearing of doctors at certain facilities not being able to get access to Discover?
Sure, and there are a variety of reasons for that. I think the biggest argument against it that you will hear is this is a disposable instrument that is expensive, and we don't want to invest in the purchase of this. The easy counter-argument for those physicians to bring to their facility is to skip the OR material management people looking at the price and go directly to senior level administration, because the minute you explain the length of stay difference between somebody getting admitted, getting an MRI, getting an ERCP, getting a day to make sure they don't get pancreatitis, getting a gallbladder surgery, staying overnight. Like, it winds up being a 5 to 7 day hospitalization depending on whether there's a weekend in the middle of that. That length of stay becomes 24 to 48 hours. We're going to the OR, we'll do the cholangiogram ourselves, we'll clear the bile duct, and we'll send the patient home. The length of stay difference is the entire, it's well worth the price of the disposable device.
And the C-suite loves that.
Of course. I mean, the C-suite loves it, but the surgeons should love it too, because it's better for patients, right? Less time in the hospital opens more beds for more patients to get procedures. It's better for patients. They're not getting 2 procedures and 2 anesthetics over several days. It's good for patients. It's good for administration. I mean, like, this is a win all around, to be honest.
All right. Can you talk to me about the SAGES Safe Chole initiative?
Yeah, I mean, the Safe Chole initiative from SAGES has been ongoing for a very long time, and the goal is just to make laparoscopic or minimally invasive gallbladder surgery as safe as possible. It includes a variety of aspects like managing the critical view of safety, but it also includes the ability to safely identify anatomy, which for especially those with severe inflammation starts with an IOC and being able to identify proper anatomy and make sure there's no stones downstream.
Okay, has that been an effective initiative?
I think it has. Yeah, absolutely. I mean, again, the goal is to move the needle in terms of the risk of bile duct injuries. You know, it remains a problem in 2024, despite the fact that we've been doing laparoscopic gallbladder surgery since the 1980s.
All right, I want to move on to PEBL, but I just want to give you an opportunity. Was there anything else you wanted to say about that topic before we move on?
Yeah, no, listen, we have seen a huge movement in the world of general surgery, minimally invasive surgery in general, to try and adopt this technique, to take back the bile duct, so to speak. I mean, that sounds like there's some war at hand here. But again, this is progress. The reasons that we didn't do lap common bile duct explorations in era of minimally invasive surgery is we didn't have the tools, the skills, the technique, the ability to do things in a way that was reproducible for the average surgeon. And now we do. And so the only reason we're not adopting this is that we have a paradigm, which is a preoperative ERCP, that just needs to change. ERCP will absolutely still have a role. There are patients who are not candidates for this. There are patients who have other diseases that need ERCP, biliary strictures, pancreatitis, and pancreatic disease. But simple stone disease should not require an ERCP to manage, full stop.
All right, so moving on to PEBL. I know
Yeah.
you just recently published an article. I'd love to hear about that.
Yeah, so PEBL, for those who don't know, is a stupid acronym that I made up a little while ago, because any good procedure needs a good acronym.
It kind of sounds cool.
Right, it does,
Yeah,
right?
yeah.
I mean, it's cutesy. PEBL stands for Percutaneous Endoscopic Biliary Lithectomy. This is essentially a procedure that's been around for some period of time, removing stones by going down through percutaneous drain tracts. Those drains may go into the biliary tree directly, like a percutaneous transhepatic tube, or into the gallbladder, percutaneous cholecystostomy tube. Basically, if there's a tube and a lumen, you can get SpyGlass down and work on removing stones. You know, somebody who's had a foregut operation that has altered their anatomy, they've already had their gallbladder out, and they have a stone that was either retained or formed in their bile duct directly. What do you do with that patient, especially if you don't have the ability to do a double balloon ERCP is not available at your facility? A lot of times a patient gets a drain into their biliary tree to decompress them, manage their acute cholangitis. You let the drain tract mature, and then you go down and get the stones out later on, and they never need a complex biliary operation. It's all done, percutaneously. But there are also a large group of patients who are going to be too sick to ever get a gallbladder surgery. We have people who are living longer, with more medical problems, and they're complex, very, very complex medically. And for those patients who are never going to get a gallbladder surgery, there are options for managing them endoscopically, like an axio stent between the gallbladder and the duodenum. But, those patients also have to be off their anticoagulation. If they leak after that procedure, if you're too sick for a gallbladder surgery and you leak from your duodenum, like that's a huge problem. And many facilities do not have a person who does endoscopic ultrasound-guided axios between the duodenum and the gallbladder, right? So there's a whole section of the world that gets a percutaneous drain in their gallbladder, and they are told, this is destination therapy. You're going to keep this drain for forever. Those patients are miserable. They hate having that drain in place. It's not very comfortable, and they have to go back for drain exchanges pretty regularly. And so the interventional radiology team doing that is also not super satisfied. And so having access to SpyGlass Discover, it doesn't matter who has access to it, whether it's the GI team or the surgeons or the interventional radiology team. If someone is willing to go down into the gallbladder, spend some time and take out all the stones, confirm that the cystic duct is open, you can clear those patients in 1 or 2 sessions with, honestly, most of them don't even need sedation. You can do it on people who are wide awake. So if they're too medically sick to get anesthesia, which is part of the reason why people don't get their gallbladder out, you can do this procedure. If they can't come off their anticoagulation or their antiplatelet agents, we just leave them on those agents. And so it's about as non-invasive as managing gallstones can get.
So are you saying those patients would then be able to get the drain removed?
Yeah, once the stones are clear and we confirm that the cystic duct is open, and then we take the drain out. There's a rate of recidivism. In some patients, maybe you missed a stone. Some patients have a cystic duct that maybe is scarred from having stones there for years. I get the question a lot, what if people reform stones? Okay, if we clear your gallbladder now and you live long enough to reform some stones and get cholecystitis again, fine, we'll just do it again in the future.
Okay.
But most patients, we can clear them successfully. They get their drains out. These are, hands down, the happiest people that you will ever meet.
And the study made it sound like it was a very simple procedure that most general surgeons should be able to learn how to do this.
Yeah, I think that there's a limited working space. You're going down a drain track into the gallbladder, and there's some technique involved with it, and a lot of it is just being persistent. When you put a camera into the gallbladder and there's 200 stones, right? A lot of these folks, like you pack a picnic lunch and you set a clock and you say, we're going to spend 2 hours doing this, and after 2 hours we're going to stop. We'll put a drain back in, and we will come back and do this again in 1 or 2 sessions. The patients are all aware up front. You may not clear them, in 1 session. But again, the opposite of that is also true. You put a scope in, and there's literally like a stone, and you take it out. It's a 20-minute procedure. You take the drain out. The patient goes about their business, and they're very happy. It is faster than taking out the gallbladder in some circumstances in patients, especially patients who are complex surgically, who have altered anatomy, who've had a ton of previous operations, and who are bad candidates for a minimally invasive operation. You're already at the target problem, which is stones in the gallbladder.
Okay, interesting. So I'm curious where you see this being the most applicable. Like, is this something that would be useful in rural facilities where maybe the interventional radiologists are too busy, or in academic centers? Where do you see the opportunity for this procedure?
All politics are local, and this probably applies to most places. My practice includes people who are very sick and who are referred to me at a tertiary care medical center for a gallbladder surgery because the local facility doesn't feel comfortable doing it. Okay, so I don't feel comfortable doing it either, but I have another tool in the armamentarium to say I'm not going to do a surgery, but we are going to take care of your stones. Maybe a facility has good IR support and they're putting the drains in, but they don't want to have to see that patient back every 6 to 8 weeks for the rest of that patient's life to change the drain. So for an interventional radiologist who is doing that procedure, they're probably saving themselves some work and a lot of scheduling problems and making themselves more available for other procedures by clearing those patients. Certainly if a group has good GI support and someone who's comfortable doing an endoscopy like that, I see no reason why a gastroenterologist couldn't do it either.
Oh, interesting. All right, shifting gears, I want to hear about the multidisciplinary approach that you guys use at Penn State. Tell me about that.
We talk about our patients regularly, and we ask what is the best way to clear this patient's bile duct. And we've been doing this now for several years, and so the group and the thought process is pretty clear across the board. Our IR group has no problem putting drains in people now because they understand that this is not a destination therapy. They're not going to have to change the drains for forever. So they put it in, and then they refer the patient to us. They're also aware that we typically like the drain upsized to a 14 French. You can do it through a 12 French drain, but 14 just makes it easier to get bigger stones out.
Is that not the norm? They would normally do a 12 French?
The first time around, 10 or 12 French is usually, yeah.
Okay.
I mean, they usually put a smaller drain in the first time around. But after that, they'll upsize it, and then once it's upsized, the patient winds up in our clinic for a PEBL procedure from IR. Our GI team now routinely sends us people who I think are a little challenging for a double balloon ERCP. So all of our gastric bypass patients, if they have a gallbladder in situ and a stone, we get a telephone call that says, hey, we know this patient needs their gallbladder out. We know that you guys have the ability to clear most of these folks percutaneously, and so, or with an LCBD at the same time. And so rather than doing an edge procedure, for example, where it's a multi-stage procedure at times, you'd run the risk of forming a fistula. We would rather our bariatric patients not have that. So we take them to the OR, take their gallbladder out, and clear the duct in most of those patients.
Do you have any tips if somebody's at a facility where maybe the multidisciplinary communication isn't as good, how they might be able to improve that?
Well, yeah, I mean, I think that just getting all of the people at the table at the same time to talk about why are we changing the paradigm, is helpful. And again, I think for most facilities, it's that length of stay argument that is important. The obvious benefit to the patient of a one-stage procedure for an LCBDE and the risk of post-ERCP pancreatitis cannot be understated. I mean, I realize it's not super common, but as a person who does ERCP and has had patients with it, it's miserable when it happens. And if I can avoid it, I'm going to do a procedure that avoids it.
Yes. Okay, this has been really, really fascinating. I just wondered if you had any closing remarks you wanted to add.
No, I mean, I think that the main, point that I'll add that we haven't talked about is for surgeons out there who are interested, there are lots of ways. Talk to your local Boston Scientific rep. There are a lot of courses. They can bring samples. You can practice on inanimate models. Groups like SAGES and other societies run LCBDE courses pretty regularly. This is something that is easily learnable by a surgeon with good laparoscopic skills. It adds a little bit of procedure time, yes, but that procedure time is billable. These are billable procedures for sure for the surgeon doing it, and this is clearly learnable in 2024.
Awesome. Thank you so much.
Thank you.
Thanks for listening to this episode of Endocast. Please subscribe to the podcast and follow Boston Scientific Endoscopy on our Twitter, YouTube, and LinkedIn feeds. You can also visit our virtual education platform, Educare. That's educare.bostonscientific.com and choose gastroenterology. The site features over 180 resources, including physician-led educational videos, lectures, case studies, device training videos, procedural tips, and techniques. Thanks for listening. Endocast listeners, an important disclaimer. These materials are intended to describe common clinical considerations and procedural steps for the use of reference technologies, but may not be appropriate for every case or patient. Decisions surrounding patient care depend on the physician's professional judgment in consideration of all available information for the individual case. Boston Scientific does not promote or encourage the use of its devices outside of their approved labeling. Case studies are not necessarily representative of clinical outcomes in all cases, as individual results may vary. Thank you.